Hello, everyone. I'm Dr. Jennifer V. Brown, your stroke specialist, and today we're going to talk about ankle movement as it relates to having the right type of ankle foot orthosis. I hope you enjoy these pearls of wisdom. So, sometimes an ankle foot orthosis is issued irrelevant to the ankle strength. You can get a solid ankle AFO, which is seen here with the black straps, or you can get a hinged ankle AFO. And sometimes I think people aren't strong enough for either. One, we put a restrictive strap up at the top of the AFO, and the leg or the tibia is not able to move forward, backwards, or rotate in when your foot pronates, get flat, or rotate out when the foot supinates. And you need all of these motions when walking. Now, I understand after a stroke, there's going to be weakness, tone, what we call spasticity, and movements are going to be limited. But you have to optimize what movement you have in order to give the best ankle foot orthoses. Sometimes we get a hinged AFO and you notice the shaft or the tibia leg part is already angled forward. You don't stand with your knee and your leg forward the entire time. It has to be able to move backwards and forwards. And that little hinge can be made out of metal or plastic. And some people don't even have the strength to move the shaft part forward. Therefore, we think keeping the leg forward is going to make it stronger and improve your walking when it doesn't. Because in stance phase, you have to balance on one leg with your hip, knee, and ankle aligned over each other. And then at terminal stance, your hip and your knee are in front of your ankle, and you have to roll over on your toes. So there are compromises to both. There's sometimes that shaft is straight up vertical, and then the foot is angled up for foot clearance. But you don't go from sit to stand with your whole foot up in the air. It has to be seated on the ground. And people don't have the strength to push it down, plus generate the force to come forward, and then generate the force to go up and sit to stand. When that foot is angled up all the time through the action of the brace, you are unable to push down and push off, increasing your steps to walk faster. So, what's critical for ankle strength? First of all, you have to have flexibility. You have to have range of motion. You need it at the knee because one of your calf muscles crosses the knee and attaches to the back of the thigh bone, the femur. You have to have adequate strength, or what I term force generation. Can you generate the force to move your body? And that muscle strength has to be isometric, a holding pattern of the muscle, concentric, a shortening of the muscle, and then eccentric, the lengthening of the muscle. The muscle lengthens more so during walking than any other muscle type, but yet we fail to train people eccentrically for walking patterns that we see. So I want you to know that you may have good strength and good movement, but once you stand up, your brain, your head is situated differently over your body. And if your cortical spinal tract, that's the tract that makes your arms and your legs move, is damaged, other descending tracts take over and they throw out all of these abnormal synergistic patterns. So here you see in this AFO a person's foot, but look at all the space there is. Look how this hard piece is covering up the first metatarsal, the first ray or bone that attaches to the big toe to keep it from supinating. But he's not doing that in sitting. He will do it in standing. You will see. So let's look at how he moves when he's in sitting. So he can pull his foot up. Well, you see him pulling his hip up. He can kick his knee out straight. Even though his foot is pointed down and in and his toe is staying up, he can raise his foot. And then it takes some effort to move it out to the side. He can push it down and push it in. but look how that big toe is up all the time. That should be a sign of an upper motor neuron lesion from the stroke. Now, he had pretty good movement sitting. All right. Let's look at him walking. Look how things change. Look at that leg. His knee is hyperextended. His hip never gets forward. He's in plantar flexion, supination with the foot rolled out. He never gets foot flat in pronation. He never gets his knee in front of his ankle, in front of his hip in stance phase. He never gets the toes to push off and roll over with that passive knee bending right before you lift the leg. It just goes to show you, after a stroke or brain injury, the cortical spinal tract can be very much damaged, and other tracts have to take over. And they take over depending on the head and the body position. He had quite nice movement in sitting. The question is, what are we doing to train those muscles when the head and the body is in a different position so walking can look differently? So these are some clinical questions I need you to ask. Is there a limitation in a range of motion? Always measure your range of motion first. R1, the first resistance to passive movement, and the final resistance you see to passive or feel to passive movement. Measure it with a goniometer. If you have a small number change from R1 and R2, it's probably a contracture. 3 to 5 to 6 degrees or greater, there is ability to move that joint, lengthen those muscles, and you have to strengthen the muscle throughout the range, isometrically, concentrically, and eccentrically. Second, was strength assessed? Was it assessed open chain and closed chain, meaning the foot on the ground? Can you raise up? Keep the foot on the ground. Can you bring your toes up and balance on your heels? Can you squat and then come back up on two legs and then raise one leg in the air and bend the knee and then straighten it by tightening the quad and tightening the gluteus maximus muscles? Two different ways to straighten the knee. Did you test it for open chain like you saw with him sitting on the mat? And did you assess those muscles isometrically, concentrically, and eccentrically? We need to differentiate those out. And traditionally, the manual muscle test is not taught that way. Is there a synergistic pattern, and when does this occur? You tend to see a lot of synergistic patterns in supine when you're laying on your back, sitting, and definitely in standing. For this gentleman, you saw it in walking when he was standing and walking. And then is the treatment focused on strengthening the muscles during the required function? Are you just giving all laying down and sitting exercises? But what are you giving for them standing up that simulates the part of walking? This is why strength training for people who have synergistic patterns, be it flexion or extension, are better done closed chain in standing as a function of walking, as opposed to giving them exercises when they're laying down or sitting. Notice all the movement he could do sitting didn't parlay or translate into the functions that he needed in walking. Remember, I am your trusted source for all things ankle foot orthosis and stroke neurorehabilitation. And don't forget about your references. We need to use the evidence in order to practice better as clinicians. Thank you for watching this video. Don't forget, like, subscribe, and share.